Low dose versus standard dose intravenous alteplase acute ischemic stroke. Definition: thrombolytic therapy for acute ischemic stroke with a lower than standard dose of intravenous alteplase may improve recovery along with a reduced risk of intracerebral hemorrhage.
Hey Ben,
Let's go.
ready?
Okay. All right, so I got my camera and I've got it rolling. So basically you came in about 11:30 tonight. You came in with having symptoms of a stroke, a right-sided stroke, right?
Yes.
And then they gave you some TPA. And what I wanted to do for this video that ends up on YouTube, I wanted to do a teaching video on demonstrating how you've improved after getting some TPA. We also want to kind of look at that little complication that you kind of seem to have with some mouth bleeding. But Dr. Garrick's here going to just do the examination. I'm going to have Dr. Garrick tell me a little bit of, when he came in, we did a cold stroke, and we saw him out in the hallway. And basically, what you on your examination, what did you find?
So on initial exam, quick hallway exam, he had slurred speech, he had decreased grip strength in his right upper extremity, decreased push-pull, probably 3 of 5 in the right upper extremity, and decreased strength in his right lower extremity as well.
Okay. And then
Mentation was appropriate.
right, because I remember when you had him try and lift his right leg, he basically could barely lift that.
Barely lifted. Left leg
And
was
he,
nice
and he had
strong.
numbness and all that.
And he had right facial numbness as well.
Okay, all right.
was
So
objective.
if you would do just a brief examination.
Same stuff that we did earlier, okay? So we'll go from head to toe. Raise your eyebrows real big, like somebody gave you a big present. Squint your eyes shut real tight. Don't let me open your eyes. Good. All right, turn your head towards my hand. Good. Towards my hand on this side. Good. Smile real big. Let me see all your teeth. Good. Nice symmetric smile now. It's a little asymmetric prior.
Okay.
Stick your tongue straight out for me. Move it from side to side.
Good evening, Garrett.
On the critical, I'm in C2. All right, thanks. All right, open your mouth real big. Say ah. Good.
So come back and do that, because we are having a little bit of some bleeding,
Open real big.
bleeding from the mouth a little bit, and it looks like it's basically somewhere in the gums. There's no obvious location, and it's not a huge amount of bleeding, but that is one of the complications potential of TPA. All right, so go ahead and do the rest
Shrug
of
your
it.
shoulders up real big for me. Very good. All right, hold your hands out like this. All right, I want you to, sorry, we got you tethered. Squeeze me real hard. Very good. Equal grip strength now.
Which he did not have before at all.
Correct. Pull
And
me.
that was
That was an hour and a half ago.
hour and a half ago.
Push me away from you. Very good. Nice, strong.
All right.
equal push. All right, I want you to lift this leg off the bed and hold it up for me for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Put that down. Lift this one up for me. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Very good.
And he could not do that
Correct.
before.
Improve lower extremity strength. Push down on the gas pedals like you want to go real fast. Good. Toes up towards your head for me. Very good. All right. And then do you feel me touching you on both sides?
Yeah, what about the sensory?
Does that feel the same now?
Feels
Okay, so
So
previously
you-
what did that feel like?
It felt like I could feel it on the left side, but the right side it was just like it was barely there.
Yeah. All right, how about down here? Equal? Very good. Excellent. Well, looks like we're
So your
improving.
speech has improved too.
Yeah, a whole lot.
Yeah. Okay. All right. Thank you so much for letting us do this.
Pros and cons. The primacy objective was to determine whether the low dose will be non-inferior to a standard dose with respect to the primary outcome of death or disability at 90 days, which was defined by scores of 2 to 6 on the modified ranking scales. Secondary objectives were to determine whether the low dose will be superior to the standard dose with respect to centrally adjunctive symptomatic intracerebral hemorrhage, and whether the low dose will be non-inferior in an ordinal analysis of modified ranking scale.
Hello again, this is Frank Gaillard from radiopedia.org, and today we're going to be discussing imaging of acute ischemic stroke. In most instances, cerebral ischemia results from a thromboembolism, either from the heart or from the carotids. Rarely it is also due from paradoxical emboli through the patent foramen ovale or from aortic atherosclerotic disease. This is seen most commonly in the setting of either angiography or cardiac surgery. In situ thrombosis within the cerebral circulation is seen either superimposed on a pre-existing arteriosclerotic disease or in the setting of arterial dissection. Imaging of acute stroke is performed either with CT or MRI. The majority of imaging of acute strokes is performed with CT, although MRI is in fact more sensitive. The reason for this is mainly to do with availability of MRI and the ability to get a patient in and out of the CT scanner rapidly without the concern for MRI-compatible resuscitation equipment. The mainstay of imaging of acute ischemic stroke is with a non-contrast brain, although increasingly in the setting of ischemic strokes this is being supplemented with CT angiography and CT perfusion. Let's focus on the hyperacute findings in ischemic stroke. This can be divided into two main sections. One is direct visualization of the clot or embolism, and this can be seen immediately, or early parenchymal changes, which can be seen as early as within 1 hour of onset of symptoms. The hyperdense artery is a well-known sign on non-contrast CT scanning and represents direct visualization of the clot within the lumen of the occluded artery. It relies on the fact that clot is hyperdense when compared to normal flowing blood. However, this depends on the age of the thromboembolism. Flowing blood typically has a density of approximately 40 Hounsfield units, although this varies depending on the hematocrit and state of hydration. Acute thrombus is not significantly denser than this. However, with time it becomes progressively more hyperdense, reaching densities of up to 100 Hounsfield units. Fortunately, the majority of ischemic strokes are due to thromboembolism, which is caused by clot forming either in the carotids or within the heart. As such, the clot that eventually embolizes and occludes intracranial circulation has been present for some time and is significantly hyperdense. In this case, we can see the right M1 segment of the middle cerebral artery is much denser than any of the other arteries are seen. In this second case, thromboembolism has occurred to the top of the basilar artery, which is much more dense than the internal carotid arteries at the same level. We can confirm direct visualization of the clot by performing CT angiography, which allows segment which appears hyperdense on non-contrast imaging to appear as hypoenhancement or a filling defect on CT angiography. The same direct visualization can be seen on catheter angiography. In this case, the M1 segment is occluded and we can see collateral flow across from the anterior cerebral circulation to supply part at least of the middle cerebral artery territory. The two regions that are affected most profoundly in acute occlusion
Ischium apply in Ecuador. This surgery can be applied in our country because there are a lot of people have strokes.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
Application medicine. Using a 2x2 quasi-factorial open-label design, we randomly assigned 3310 patients who were eligible for thrombolytic therapy to low-dose intravenous alteplase, or the standard dose. Patients underwent randomization within 4.5 hours after the onset stroke. Conclusion. This trial involving predominantly Asian patients with acute ischemic stroke did not show the non-inferiority of low-dose alteplase to standard-dose alteplase with respect to death and disability at 90 days. There were significantly fewer symptomatic intracerebral hemorrhages with low-dose alteplase.